perforating vein is still a difficult topic, and I will try to explain you what we can achieve with ultrasound-guided foam sclerotherapy. We know that anatomy is not sufficient to distinguish between competent and incompetent perforating vein, even if incompetent perforating vein diameter is often over 4 millimeters. Hemodynamic of perforating vein is very complex with different kind of flux or reflux, and we can use this systematization with refluxing perforating vein during systole and diastole. This is a bidirectional perforating vein with reflux in systole but flux in diastole. And this is a re-entry perforating vein with flux going only in the right way from the superficial to the deep venous system. What is the interest of treating perforating vein is to decrease the high venous pressure, but these studies show that the treatment alone of perforating vein is not sufficient to normalize ambulatory venous pressure, and on the other hand, occlusion of the GSV is sufficient to decrease this pressure. This study showed that if you associate SEPs to treatment of the superficial venous system, there is no difference about pain, about mobility, about quality of life, but you will just decrease the number of refluxing perforating vein at 1 year follow-up without any clinical relevance. In this study, Stuart learned what happened after eradication of the main stem saphenous reflux. And if you treat the superficial veins, you will observe a decrease of the incompetent perforating vein numbers, a decrease of percentage of incompetent perforating vein, and a decrease of the diameter of this perforating vein. This meta-analysis showed that treatment of incompetent perforating vein doesn't change significantly the time of ulcer healing, but only ESCAR study shows reduction in recurrence after treating incompetent perforating vein. What happened after combined minimally invasive treatment of venous ulcer? 86 patients have been treated with 95 ulcers. It's a retrospective study. And the treatment that was proposed was radiofrequency of the GSV or small saphenous vein, sclerotherapy of perforating vein, association with sclerotherapy and radiofrequency or radiofrequency phlebectomy and so on. And this study showed that combined treatment, associating treatment of perforating vein but also of superficial veins, will increase the percentage of healing significantly. It will decrease the recurrence, and it will increase the time until the healing. And the only predictor of healing weight was the interventional treatment. This is a study that shows that ultrasound-guided Fox flow therapy is very effective for the treatment of ulcers. And in this study, they note anecdotally that even if the perforating vein was not treated for themselves, they observed that a lot of perforating vein was treated in the same time than superficial veins. And this is a study that shows that the elective treatment of perforating vein is efficient to increase the healing of ulcers. And this study was achieved with thermal ablation in patients with only perforating veins and no more incompetent superficial networks. So I think that we can agree with the guidelines of the AVF. They recommend against selective treatment of the incompetent perforating vein in patients with simple varicose veins, like C2. They suggest treatment of pathologic perforating vein that includes those with outward flow over 0.5 second duration, diameter over 3.5, located beneath ear or open venous ulcer. And for the treatment of perforating veins, they suggest SEPS, ultrasound-guided flow therapy, or thermal ablation. Some consideration, what we see in the current life. At the thigh level, this is the aspect of a perforating vein, but if you use a low-frequency probe, you see that the course of the perforating vein is very long, and there is also ramification. And of course, in such a case, surgery is not efficient to treat this perforating vein. Thermal ablation, no, and you have to use foam flow therapy. This is a view of the course of the perforating vein with the first tributary, a second one, and a very long course through the muscle to the deep vein system. You see here tributaries. So you have to remember that thigh tributaries are very complex vein system, in fact. And we have to differentiate the different situations. In such a case, there is a reflux into GSB and an associated refluxing perforating vein at the thigh. You can treat it with foam that will fill the GSB and the perforating vein. And with thermal ablation, we just treat the superficial network. In case of elected incompetence of this perforating vein with competence of the termination of the GSB, the foam will fill the incompetent part of the GSB and also the perforating vein. And with thermal ablation, myself, I just treat the incompetent part of the GSB, and then the reflux will drain normally into the competent part of the GSB. This is what we see after ultrasound-guided foam flow therapy of this perforating vein, which is occluded. But in some cases, you see that even with foam, you have the same process. The foam fills the incompetent part of the GSB, and the foam will not fill the perforating vein nor the termination of the GSB. This is a result of a segmental treatment of the refluxing GSB. Before treatment, the reflux comes from two perforating veins into the GSB, and after treatment, the reflux drains normally into the competent part of the GSB. You have to remember that re-entry perforating vein, there is some re-entry perforating vein at the thigh level, and the flux going to the deep system, you don't have to treat this perforating vein. And at the leg level, there is a lot of re-entry perforating vein. For example, this gastroduodenian perforating vein that drains the flux from this tributary into the deep venous system. This perforating vein doesn't require any treatment. At a leg level, on an anatomical point of view, you see that here it's a Coquette perforating vein. This perforating vein is very, very, very short. This is a superficial network. This is the tibial vein, and you see that this perforating vein is large and less than 1 centimeter. So I think in such a case, surgery or thermal treatment is a better option than for sclerotherapy, because you will feel the deep venous system before approving the perforating vein, but you can treat the superficial veins. And also, you have to know that hemodynamic analysis is sometimes difficult, and flux or reflux will depend on the type of maneuver you use to elicit reflux. Here is a bidirectional perforating vein with flux or reflux according to the maneuver. This is another point. A patient with a very large venous system and a re-entry perforating vein. But if you suppress the superficial veins, you decrease the pressure into the superficial veins, and this perforating vein will become incompetent. Also, the anatomy and hemodynamic is sometimes very complex. You see here a perforating vein, but there is a duplication of the perforating vein with flux on one axis and reflux on the other one. And this is a triplication of the perforating vein with one refluxing axis and two competent axes. That's the rule. There is always duplication or triplication at the leg level. And here you see with ultrasound a very nice perforating vein with a reflux. It's on a transverse view, but if you look at a sagittal view, there is duplication of this perforating vein, and one more time with one refluxing and the other competent. And finally, you have to remember that these perforating veins are often related to deep venous reflux. You see here the reflux in the perforating vein, but there is a reflux in the posterior tibial vein and also in the popliteal vein, and you have to achieve a complete examination. So in conclusion, duplex analysis of perforating vein anatomy and hemodynamic is mandatory. You have to distinguish between thigh and legs perforating vein. They are anatomically different and hemodynamically also. There is no interest to treat specifically legs in competent perforating vein in patients with mild chronic venous insufficiency. Patients with C5, C6 are candidates for ablation, combined with endovenous ablation of the GSB or following endovenous ablation of the GSB. Ultrasound-guided foam sclerotherapy often allows to treat superficial veins and incompetent perforating veins in the same time. And if you use ultrasound-guided foam sclerotherapy for incompetent perforating vein ablation, this sclerotherapy must be given with utmost attention. The maximum volume is up to 4 millimeters. And you have to avoid direct injection into the perforated vein because there is a lot of arteries around this perforating vein, as you have seen yesterday. Thank you very much.